Dr. Amber Klimzak.
And we are
Two Peaks in a Pod.
Well, hello, Dr. K, and welcome back, everybody. How's your week been?
So far, so good. My kids went back to school, so we're already, getting the plague from the cesspool that is preschool.
Yes, so many little viruses going around. And actually, I've had a couple of patients tell me COVID is going around again, too.
Oh, gosh.
All that stuff, yeah.
Hopefully no COVID for us.
Yes. Okay, so you know how we always talk about a pop culture reference to fertility, and we got a request from one of our listeners. Thank you for requesting, and she wanted me to bring up an article that actually came out, I think it was probably earlier this year, when Jennifer Aniston had opened up and shared some things about her fertility journey. And so let me tell you what Jennifer Aniston said. She said it was really hard. I was going through IVF, drinking Chinese teas, you name it. I was throwing everything at it. I would have given anything if someone had said to me, freeze your eggs, do yourself a favor. You just don't think it. So here I am today, the ship has sailed. And
it's tough.
So tough. So had you heard about it when that came out?
Oh, yeah. I love Jennifer Aniston. I'm a huge Friends fan. I feel like she and I are, basically best friends. I watch Friends every night before I go to sleep, so I feel like I am one with Friends.
Yes, and same thing too. I think that's something we really bonded over, which I loved because I'm kind of older, so I didn't know if you were old enough to even know about Friends, so I'm glad that you do. And I guess for our patients that see us, our very first employee we hired is named Chandler. And we had to hire her because she had the name of one of the Friends characters. So yes, we're both huge fans, I think. And I think we've both kind of watched her journey throughout the years, right?
Yeah, and I think there was probably always that question. I wondered it because in any time, like a woman, I know she was kind of in and out of relationships. Mm-hmm. And I did always think it's kind of unusual for a woman never to even talk about having children. I think she would always I hate like the terrible magazines, but she would be wearing a particular outfit and it would be like Jennifer Aniston bumping, like how painful that must be for her, constant, like everyone would bring it up. So you definitely wondered, does she just not want children? I don't think anyone suspected really that she was going through IVF and having this private journey, trying to salvage, much later in life. It's really neat that she was able to be vocal about that. And certainly I think she probably helped a lot of young women.
Yes, I think really even that article has kind of changed how the media is even presenting current celebrities as well. I think people are realizing just how terrible that is to do to people. But, unfortunately, I think I was even a part of it too. Like I was reading the magazines too, like, is she pregnant? Because I think we were so excited for her and so hopeful and everything. But of course, none of us knew that at the time she was undergoing those treatments, and that just has to be the worst. Maybe you're bloated because you're in the middle of an IVF cycle that didn't work. And I mean, I just can't even imagine that is the absolute worst. So my heart really goes out to her for all of those things. But I'll have to kind of tell you too, as I read the article, I had to catch myself because she's kind of mentioning some of the things she tried, right?
Yeah. Mm-hmm.
And here I am myself thinking, well, but did you try this? Did you try this? What about this?
Yeah.
And then I was, like, well, okay, even if you can't get pregnant with your own eggs, you can use an egg donor. And I kind of, my head was just racing with all these ideas I had for Jennifer Aniston, right?
Come see us, Jennifer Aniston.
That's right. You just didn't come to Peak Fertility. Like, come on. But then I realized, that's not what she needs, right? Is anybody trying to go and question her. And honestly, I think that's a really hard thing because, you and I, as any fertility doctor, have had doctors that we do everything we can and we're struggling to help them get pregnant. And sometimes our technology has not advanced fast enough to help somebody. And my patients have told me it's so hard and frustrating when you've got all these family and friends that are trying to give all their advice to you on how to help you get pregnant. It's really even more stressful.
It's incredibly stressful. And just the questions, and I always say, like, silence speaks. Like, if you have a friend, perhaps you think she's of childbearing time in her life for whatever reason. You think that she's at some age or some point in her life that you would expect, maybe they're interested in having a child or something like that. If they're not talking about it, there may be a reason, So I always kind of keep that in my mind. I've try not to ever probe. I mean, of course, with the line of work we do, I often get asked a lot of questions and know a lot of private stories from my friends and family, but silence is something that probably means a lot.
Yes, I think that's so true. And so, if they bring it up, that's great to talk about it and offer support and all of that. But I really think, too, the best support sometimes you can give is, hey, I'm here for you. If you want to talk about it, great. Probably the best support is not like, hey, you need to do this or you need to do that or you should have seen my doctor. My doctor's better than your doctor, all those things, because that can just create a lot more stress, I think.
A lot of anecdotal experiences.
Yes.
I have a lot of patients that come to me, well, my friend, she did this and she got pregnant, and then a lot of times what they're going through is totally different than what their friend went through. Or I do find it's like the older aunts, the grandmothers, that like to give their advice on how they think, someone should get pregnant. It's often, not very well vetted advice.
Yes. Or how about the just relax?
Just relax. Just relax. Yeah. And, you're too tense. That's why you're not getting pregnant. I think probably all of my patients have heard that at some point, and I think it's infuriating. I definitely heard that when I was trying to get pregnant, and I'm like, listen, I'm never going to relax. This is the way I am.
That's true. Yeah. Well, and too, like, sometimes I've had patients who had been trying for years, and they said people kept just telling them to relax, and then we just come in for their appointment, we do the testing, and we find out, the sperm is extremely low. There's 2 sperm. Okay. Yeah. Look, you can do all the relaxing you want, but there's a problem here, and sometimes patients have a delay in seeking care because they've been given poor advice by people who I know are just well-meaning, though, too. Yeah,
definitely. Yeah. I'm curious, in the Jennifer Aniston article, did she mention anything about timeline? When was she going through
and
this?
I was kind of curious about that too, because I thought her and Brad Pitt were so cute together. So that was my kind of teen crush when I was in high school.
I think it was everyone's crush.
I used to work at Blockbuster Video. That was my first job, and because I worked there, I could get the free cutouts, and so I had a life-size cutout of Brad Pitt in my room. So I just thought they were the cutest and all the rest of it. So I am curious if they had tried to get pregnant, but I don't know.
That's what I'm curious too.
But it may not have been until I think it's her second husband, Justin, that she was with. And that would make more sense because, she would have been older at that point when they would have been trying IVF and everything.
Yeah. Well, we know Brad Pitt can have babies.
Well, that's true. Yes. Well,
he's got his fair share of kids.
I know, and that was just kind of sad too. And honestly, if let's say they have been trying, right? Again, how painful would that have been if Jennifer and Brad were trying together, and then they divorce, and then he goes and has a bunch of kids with somebody else? Like, again, this woman has been through a lot. She really has been, but she stayed just so strong and resilient and successful, despite all of that. So, but I couldn't help but wonder, had she tried donor egg? And I'm like, really, when she says the ship has sailed, I'm like, it hasn't sailed. It's not too late. I know. My oldest patient who had a baby is 56 years old. I'm like, she's got plenty of time. But that's when I really had to kind of check myself and say, look, what's really hard to do too is to know when to stop. That's a very personal decision, and that's not for me to try to tell anybody, And I think that kind of what she describes in the article is that when she got to that place when she wanted to stop, she almost had peace about it at that point. Yes, she would have changed things. She would have frozen eggs if she could have. But also once you decide to move on, it takes probably some of the stress out of it as well. So I had to kind of remind myself of that part.
Absolutely. And, for our listeners too, I mean, we always really dive into fertility treatments and, how can you be a mother that way? But also there's lots of ways to make a family too, like, I don't know if she ever investigated adoption or fostering, so there's just so many options if you have a family.
Yeah. Well, okay, today I wanted to kind of ask you what you advise your patients who are wanting to go more the natural route. So certainly by the time a lot of our patients have seen us, they have already tried a lot of things naturally on their own. And I've just found my patients are just so well educated and sophisticated. By the time that they get to me, they've done all the things. And so usually when they see us, we're doing the testing, we're doing the treatment. Right. But every now and then I'll get somebody who actually hasn't even tried at all to get pregnant yet. And they'll just say, hey, I'm about to start trying, so what would you recommend? And so I'd love to kind of hear some of the basics that you usually recommend for your patients.
Yeah, absolutely. I've actually had a few patients that will come to me for a preconception session where we'll review that they're thinking, hey, in 6 months, my partner and I are not ready now. It's not the right time in our life, but maybe in 6 months we're interested in trying. And I actually find it extremely helpful because at that point they usually haven't gone down this road of, I have an app tracking my cycle, we're timing intercourse, all of these things. So it is nice to kind of lead them up to it, and they know already, they have a good understanding of what's worth it, what's not, right? And so what I tell my patients, usually if they're just starting fresh, is we've got to track your cycle, so pay attention to your cycles. There are so many good apps out there. I think 99% of my patients have an app now on their phone that tracks their cycle because it's just hard to remember. So just anything simple that's tracking your cycle. Day 1 is first day of full flow bleeding. Sometimes that's something that kind of throws people off as well. You may have spotting leading up to your cycle, things like that. So count the number of days between the cycles. Typically, ovulation is going to happen mid-cycle, right? About 2 weeks before your expected next period. And so I counsel them on that, and this is sort of your peak time to conceive. And then the other thing that I see a lot is that if they know that, they tend to have intercourse back to back to back to back right during that time. And so I always recommend every other day around the expected time of ovulation. I definitely have women who use ovulation predictor kits, OPKs, which tracks a hormone that you release in your urine called LH that rises before ovulation. So keep in mind that is going up when you first hit that, or the peak. You're going to ovulate sometime after that, okay? I hate ovulation predictor kits. I don't know how you feel about them, but I tried using them myself. Of course, I have my own issues and they didn't work for me, but I do have a lot of patients that I feel like they put a lot of time, money, effort into OPKs. They're not always accurate, and I think that it can add to the process just a lot more stress, and you're trying to interpret them. And so I just say, hey, let's estimate this is probably the window around which you're ovulating, have intercourse every other day. I try not to give them too many things to keep up with. So if they're already using ovulation predictor kits, they feel fine about it, then, that's one thing. But I do have a lot of patients that come in, they show me their pictures, they're like, I'm lost. I take these every day. I have no idea what they're saying. The other really just basic things for the preconception counseling sessions that I do, make sure they're taking a prenatal vitamin. Even if they're not planning on conceiving immediately, we know that you build these things up in stores. Folic acid is super important for development of the first trimester fetus. And so we just say, start taking it now. Any woman, reproductive age, take a prenatal vitamin. So we make sure we go over their medication list, make sure they're not taking any medications that could potentially be harmful if they did get pregnant. We talk about what type of contraception they've been using up until that point. Most contraceptions are really nice. Once you stop them, you immediately return to your baseline fertility within just a few weeks. Other forms of contraception, like some of my women may have taken Depo-Provera, which is an injection of progesterone, and that can actually have some lingering effects, not necessarily on your fertility per se, like you're going to have trouble conceiving, but it lingers in that you're not going to get a cycle for some time. You're not going to start ovulating regularly again for some time. So it's nice to anticipate that if someone knows that they're on that. So we kind of discuss what they've been using up until that point. I think it's helpful.
Yeah. Well, it sounds like we do a lot of things pretty similarly. I think the other thing that I know you do too, and we talked about in our very first podcast, is always offer everybody genetic carrier screening before they're looking to conceive. For prenatal vitamins, I am curious, do you have a certain prenatal vitamin that you recommend? I get this question a lot.
I get this question at every single visit, and obviously, I'm not financially involved with anyone, so I always say whatever prenatal vitamin you're willing to take on a daily basis. So I've had experience with a lot of the ones that have iron in it. I think they're horrible.
They're the worst.
They're the worst. So I usually say you're probably not going to stick to it. It's going to make you constipated. So let's get a basic prenatal vitamin. And I always say they have the gummies now. And women really like to take gummy vitamins. All my vitamins I take are gummy. So I'm like, if that's going to encourage you to take it, let's do that. And they tend to not have iron because of the way they're compounded.
Same thing. I think my biggest thing is I just say check your label, see how much folic acid in it. I will say that prenatal prenatal vitamins are regulated in the U.S., so
Yes.
they do have to contain the minimum amount of folic acid, which is 400 micrograms, in order to call themselves a prenatal vitamin. So you are good. I will say, y'all know me, I like to be a little extra, and so I do like one that has at least 800 micrograms.
I think they
of folic
usually have
acid.
800. I've been kind of neurotic before
Yeah.
shopping for my own, and I looked on the shelf. I rarely would find one that doesn't have 800.
Yeah.
So.
But then another confusing thing is sometimes it'll say folic acid, sometimes it'll say folate.
Yes.
If it's folate, then it's a different amount. It's around 1,300 micrograms. But either way, I just feel like you want to have a ton of folic acid, and I'm really basing that off just lots of studies I've seen over the years that taking folic acid before you conceive results in lower chance of having a child with birth defects and autism, and even perhaps lower chance of miscarriage. And then I even saw a study, and this is why I used the 800 micrograms, of patients that did IVF. The ones that had the 800 micrograms of folic acid had a better IVF outcome. So I really kind of just use that and apply it to all of my patients and say, look, if it helped people with IVF, it probably helps everybody with fertility as well. So, but same, I'm not picky about brand names at all. In fact, I say probably don't buy the most expensive. I'm like, just because it has a picture of a cute baby on it does not mean it's any better than the rest. And so I'm really just more concerned with mainly the folic acid in there.
Yeah,
so.
by far. Right? And most women's daily vitamins too. I have a lot of people who come to me, I'm not taking a prenatal, but I'm taking a woman's vitamin.
Yeah.
They're actually fairly good at having the correct amount of folic acid as well. So
That's
you can feel
true.
reassured by that.
That's true. And then I remember we had talked before, I think we both are recommending people take vitamin D as well. A lot of prenatal vitamins do not have a large amount of vitamin D in there. So I'm usually recommending about 2,000 IUs of vitamin D per day. Yeah. So I think that's good in terms of just preparing. Okay, so then the apps, do you have a favorite app that you use?
Not necessarily, because I mean, this sounds crazy, but I never got an app to track
Okay,
any of my
you
cycles.
don't track.
So
I was going to
yeah,
ask you if you track.
I definitely don't track right now. But
Yeah. I mean, I've used some different apps over the years, but it's been kind of annoying because lately these apps want you to sign up for a subscription and pay like $2 a month, which I know it's only $2 a month, but I don't want to have a subscription for an app. Like, just give me one free like they used to do in the old days.
I was laughing. My patient was telling me some of the names. Do you not think the names of the apps are kind of hilarious? So I've heard Flow a lot. I think people use the Flow app. It's pretty common. Someone yesterday told me about an app called Drip.
Oh, jeez.
I was like, no, that is not the name.
I'm going to guess that wasn't made by a female.
It sounds like a coffee place or something. But yeah, I think they've really, a lot of the good names are probably used for apps by now, so we're down to the bottom of the barrel.
And so, interestingly, I think I saw a study within last year that showed now that there's data proving that if women use apps, they do have better chances of getting pregnant on their own. So I definitely think that using an app makes a lot of sense. However, there are certain patients that an app will not work for. And here's the thing. The app is a computer, right? It recognizes patterns. So if your periods are very regular, meaning they are happening, for example, every 28 days or every 32 days or whatever, if it's at an even pattern, yes, your app is going to recognize that, and it's just going to count backwards. So if your periods come every 28 days, it's going to say 28 minus 14, and it's going to say that is the cycle day you're going to ovulate on. If your periods are every 32 days, it's going to take 32 minus 14 and say that's the cycle day that you're going to ovulate on. But if your periods are irregular, so let's say 1 month they come after 26 days, and then the next month it comes at 35 days. Okay, you're going to confuse your app. It's not going to know what's going on, and even worse, it's going to tell you the wrong day to try on. And so I think that's probably the most important thing. I wish that apps even had almost like a warning of like, if let's say you track 3 months in a row and your periods are coming on different cycle days, I feel like a warning box should pop up and say, go see a fertility doctor because you need help figuring out exactly when you're ovulating, or this might be a circumstance in which getting ovulation predictor kits is more helpful in somebody like that.
Right. Or, I mean, I think it's also nice now for women who are tracking their cycles with apps. They recognize much sooner, hey, I'm having irregular cycles. And we know, hey, that's a cause for concern. Probably not ovulating. Come see us so we can help you out with something like ovulation induction. So even tracking your cycles on an app, most women, I think there's a lot of awareness now about cycles. Most women kind of recognize, oh yeah, my cycles are irregular. That's why I came to see you. Something was wrong.
Yeah.
And so it does help you pick up on it sooner. I think if you're just kind of like living your life through your 20s, you may not be paying attention to it until you're ready to conceive. And they're like, oh, my cycles are very irregular.
Yes. Well, and I think too, you've probably seen this happen. Sometimes I'll have a patient, I'll say, how often do your periods come? And they'll say once a month. Okay. But maybe it might be coming early in the month or late in the month. I mean, it is pretty important for us to know. So I love when patients come with their app and they show, they've got all the data ready for me. That really helps me to kind of know what's going on. Because here's the thing, if somebody is having a period at a regular interval every single month, 95% of the time they are ovulating on their own. That's a very important thing for us to pick up on. Yeah. If somebody tells me, oh, I have a period every 3 months, I already know you are not ovulating every month. That is probably one of the major problems in that patient's case. And so, that's kind of where I always feel bad when I see patients in that circumstance who are trying apps and ovulation tests and all the rest of it. I'm like, from that piece of history alone, you need to come see a fertility doctor or an OBGYN if they feel comfortable doing fertility treatment as well.
Right. Yeah. And it is kind of frustrating because some people have in their mind, maybe it's from a prior doctor or something, well, I need to try for a year. They have this, well, we're young, we just started, we need to try for a year. Well, you definitely don't need to try for a year if you're having irregular cycles, right? Because you're not ovulating. You may intermittently ovulate and perhaps you could get pregnant, but it's going to be pretty slim chances. So come see us sooner. You don't have to be trying for a year if you have irregular cycles.
Right, exactly. Because if you're not ovulating, you have a 0 chance of getting pregnant. And so why waste the time when we can see that there's clearly an issue right then and there. So
the other thing it helps a lot with is short cycles. I think a lot of women will track and they're noticing, I just have cycles. My window from one period to the next period is short. Maybe even they've noticed it's getting shorter, and that's also another tip off for us. That tends to indicate that maybe you're dealing with lower egg reserve or egg supply than ideally we'd like to work with. So another reason, come in and see us sooner. Hey, I'm having really short cycles. This is unusual, or I've been tracking it and they seem to be getting shorter and shorter. That's another reason to come see us sooner, because the sooner you come see us, right, time is on our side. We may have more eggs to work with.
Yes, yeah. Okay, I wanted to bring up some fertility advice from another podcast I listened to, which is, well, I was going to say totally different than ours, but I will say it's a pop culture podcast, but she's a comedian. Her name is Heather McDonald. She has a podcast called Juicy Scoop, which I love. She talks about celebrities and just tells funny stories about it. But somehow, for some reason, she came up with this advice, and I actually think it's pretty decent advice.
But she's not like a fertility doctor?
She's not
just
a fertility doctor.
This
she's
is great.
Just a comedian, like a celebrity. But,
okay.
But I think it's actually pretty good advice. So for people who don't want to do apps and ovulation predictor kits or anything, she says, look, you start your period, you wait until your period ends, okay? Then after that, have intercourse every other day. Yeah. And she was like, call me when you're pregnant, And I'm like, I think that's good advice, because it was kind of mentioning that every other day that you're.
I used to tell people that a lot. Yeah. Actually, I just think that people want more specific timing.
Sure.
And it's funny. I get a lot of guys who say that's too much.
Yeah. I'm surprised the guys. Usually the guys are fine. It's just the women are like, that's too much.
I know a lot of guys are like, it's tough to do it that much. I'm like, okay, well then let's pick a more finite window where you can do it every other day.
Yeah. Okay, so then I wanted to touch on ovulation test. Okay, so I think ovulation tests are great. I definitely used them myself, but they don't work for everybody. So I think that's the number one thing, is to point out that some patients with infertility, in particular patients that have PCOS, polycystic ovarian syndrome, polycystic ovary syndrome, can have a very high risk of getting a false positive on these ovulation tests. The ovulation tests are to detect a hormone called LH that is released from our brain. And women who have PCOS often have high LH levels all the time, whereas women without PCOS will only have high LH right before they're about to ovulate. So I think that's an important thing to kind of keep an eye out. If you're a patient and you keep getting positives every day, those are false positives. When women have a true positive, the way it'll look is it'll be negative, 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 positive. Maybe it's positive for 1 or 2 days, and then it should go back to negative again. That's kind of more of a
Something to clarify too about
Yeah.
ovulation predictor kits. When we say a negative test, so it's different than a pregnancy test,
Yes,
right?
that's a good
Traditional
point.
ovulation predictor kits, now they have more advanced ones, maybe they
Yeah.
have more clear results, but very basic traditional ovulation predictor kits, they have 2 lines typically, and in order for it to be positive, it needs to be at least as dark or darker than the line that's usually always there as a control. And so if you take the test and you see 2 lines, but that second line is faint, that's a negative test.
Yeah.
And I think that just can make someone a little crazy too,
Yeah.
like interpreting, is this dark or darker?
Yeah.
So, but what she's saying, when you have negative, you're still gonna have 2 lines, but it may be very, very faint, and then it's gonna get dark, and then it will gradually fade away again.
Yeah,
So.
and I think that's such an important point, because with pregnancy tests, it's the opposite.
Yes.
Any little line you see, if it's faint, if it's a squinter, as they call it, that's a positive. So I think that's a really good point to bring up. That's it, because it's very different in that case.
Yeah, absolutely.
Yeah.
And so women with PCOS, what I've seen actually happen is they were testing around the time that they think that they may be ovulating. And a lot of women with PCOS can have regular cycles, right?
That's
so
true.
they're testing and they're like, I get a positive ovulation predictor kit, because they're only testing when they would expect to be, and it's dark, and they're like, it's working.
Yeah.
And then come to find out they have PCOS, not ovulating. So.
Yeah. Okay, so when it comes to ovulation predictor test, it's really entertaining actually to go shopping for them now, because they have the fanciest ones now. I saw one that has Bluetooth. Like, it has Bluetooth, so it'll zap it to your phone so that you can, I guess, put it in whatever app of what's going on.
That's funny.
But I mean, I think it was like $55 or something, and I'm like, I hope patients aren't really spending this much money on this, because that is a huge waste of money in my opinion.
You
What
can
do you think?
Bluetooth it to your husband.
That's right.
Peak ovulation. Keep it romantic, so he just knows you don't even know.
That's right. So I will say I'm a big fan. Well, I always love to save money, right? So I'm a big fan of Wanfos. You can get a huge bag of them off of Amazon, and they're just these tiny little strips. And that way you can and I think a huge bag comes with ovulation test and pregnancy
They have the
test.
pregnancy test too. Yeah.
I think they're really accurate. I've had a ton of patients who use them. My patients are the ones who taught me about it, and I think they're great. You can just pee on one every single day, and usually people line them up and use a Sharpie to put what cycle day they are. I love looking at them. I think it's really cool. So I think that's a good option. Do you have a certain ovulation test you like patients to use?
Not necessarily. Again, because I rarely recommend them to patients. If they're doing them already, then like I said, it's fine. Occasionally I'll use them in cycles if we can't get blood work and things like that. So
the one that really kind of drives me crazy is the Clear Blue Digital Advanced. And I will say that's a really common one that people use. But the problem with this one is it kind of has 2 types of positive. So it's not only detecting the LH surge, but it's also detecting when estrogen starts to go up in the body. And I can understand how that may be helpful, for example, for a PCOS patient to try to make sure they're not getting a false positive. But when there's 2 types of positives, sometimes I've had patients call me too soon. They'll say I have a positive, but it wasn't like the peak positive.
Interesting.
And so that one is one that has sometimes created a lot of confusion for my patients.
Does it delineate? How does it?
So basically, it's a digital one. Okay. So I believe what happens is when the estrogen starts to go up, I think it starts a flashing smiley, and then once it's actually the LH surge, then it turns solid.
Solid smiley.
But imagine if you've been getting nothing, and all of a sudden you get the flashing smiley. Then you're calling and saying, oh my gosh, I'm about to ovulate. Because sometimes people will panic. They're calling, I'm about to ovulate. And we're like, no, you're not ovulating yet. So, again, it's just one that sometimes causes confusion.
Yeah, we should clarify the reason why estrogen is important is because when you're growing a big follicle that's getting ready to ovulate, your estrogen level is going to rise. So we say 200 for 2 days. So if you've had an elevated estrogen level, at least that level for a couple of days, it's probably going to be close to ovulating. And so that's what that's detecting.
Yeah, but kind of back to the more natural ways too, there might be some other ways of detecting when your body's estrogen levels are going up. So do you ever tell patients to kind of look for their natural body signs?
I have patients that have done it.
Yeah.
So basal body temperature, things like that. I think that's even harder than ovulation predictor kits.
Yes,
if you're doing basal body temperature, you have to do it first thing in the morning. You're supposed to stay in bed, not eat or drink anything, take your temperature before you even start moving, and kind of record it. So we know that, you can monitor that as well. Some women check their cervical mucus. That's another sign that your estrogen level is getting high. I rarely have women that are checking their cervical mucus. I have a couple that have come in and told me.
I have tons of people actually that do. Oh yeah. And so really what you're looking for is just the real clear, stretchy discharge. I'd say it's almost like egg white discharge. And I do think it's nice, especially for my patients that have premature ovarian insufficiency. So in these patients, oftentimes their LH that comes from their brain is high just all the time. But the thing is, these women are often capable of every now and then ovulating, okay? But how are they going to know that? They can't test for themselves at home. And so one of the things that they can really look at is their vaginal discharge. If out of nowhere they went from having a lot of vaginal dryness to having a lot of that clear, stretchy vaginal discharge, that could be a clue for them. And sometimes I'll say, look, if you start to get that, just call me, come in, we'll do an ultrasound, and then I can confirm for them whether or not they do actually have a follicle. And then sometimes we try to jump on it and capitalize on that moment. So. I think the thing to point out about the basal body temperature, because I have a lot of patients who do that too, is unfortunately with that, you don't find out about it until after you've ovulated. So I think it's nice information just to kind of track as a whole, but if you're waiting until it goes up, you've already missed the window. Because so I guess the concept here is that after you ovulate, your progesterone level will go up, and progesterone makes your core body temperature higher. But by that point, your egg would have already been released, and you've kind of missed the window. So it's kind of more something you can track over time to just kind of know when does this usually go up, so that you can try to be trying ahead of time.
Yeah. The few women that I've seen doing it, they have like a long log of all the months, and that's really the way to do it if you're going to do it. You have to kind of know consistently and then anticipate for the upcoming cycle when you should have intercourse.
Yeah, and I think this brings up a good point too about whenever you ovulate, really the best time to be trying is the day of ovulation and the day before.
Oh, yes.
But the day after, essentially zero chances of getting pregnant at that point.
Really good studies to show that. I told all my patients that when they looked at this, there were no conceptions that happened the day after pregnancy. Quite a few happen on the day of, and many from the days leading up to. So, sperm can survive in the cervical mucus, kind of waiting there for the egg. So leading up to ovulation day is probably the most important. I have a lot of patients who, may have partners or they travel. So this is actually really relieving for them to know around the time, okay, so I need to be with them before ovulation.
Yes, and they say sperm can live in the body up to 5 days. And so, really, and it's kind of dependent on if you're doing every other day or whatever you decide, leading up to, that's great to be able to have intercourse there. I will say it's kind of funny. I have seen the two sides fighting about this before. Is it every other day or is it every day? Which one? I feel like I'm more of an everyday person.
Really?
But I will say that's if you're doing, ovulation predictor tests and they work for you, I'd say yes. So if you get a positive, I would say go ahead and have intercourse that day and the next 2 or 3 days. The day of your positive, so you get your LH surge, but you're likely not to ovulate until the next day. So that's kind of why I tell people that. But I know that I see both sides to it. I think it's kind of funny when people fight about it, actually.
It's hard when you're just using ovulation predictor kits because it depends on where are you detecting. So we know the entire length from start of the LH surge to end of the LH surge, it's somewhere around 39 hours, but are you catching it at the beginning, and that's when you're first picking it up, or are you catching it towards the end? The studies show it starts around 2 o'clock, 3 o'clock in the morning for a lot of women, probably not testing then, so you may be testing on the early rise, hopefully if you're testing first thing in the morning, so it's hard to know if you're catching the tail end of it, man, you gotta get busy quick.
Yeah, that's right. And actually that brings up another good point too, time of day for testing. I'm really, at the end of the day, I say people can really test whenever they want, but this is where pregnancy hormone test and LH testing can vary a little bit. So usually for pregnancy testing, we're saying first thing in the morning, first urine of the day. For LH testing, sometimes they say maybe even in the afternoon might be more likely to catch it. But sometimes you kind of, just have to be flexible, especially, so sometimes for my purposes, if I'm doing a treatment on a patient and I need to know if they have a positive test because we need to do a procedure on a weekend or something. I'm like, no, we can't really wait for you to do it in the afternoon. Just do it in the morning and it should catch it too, even if the levels sometimes aren't higher until later. But
right, yeah, I think some of the manufacturer labels actually want them to take them first thing in the morning because that's when, same thing as pregnancy test, it's most concentrated and most likely to pick it up. But you're going to have a much higher later, level later. Like I said, if you start that LH surge in the middle of the night, probably by the afternoon, it's going to be high enough to pick it up as well. But we tend to drink a lot of water too, so you can miss it.
Yeah, so you'll see different things, but I'd say it's not really anything to stress about, and any of those things would be fine. So, okay, so another thing is when it's time. So you're about to ovulate, it's time to do it. Sometimes it is hard because I think you kind of alluded to this before. Sometimes that puts a lot of stress on the guys. So some of my
parties, I think both parties.
So I know some of my patients will say, you know what, sometimes they don't even mention to their spouse that they're in their fertile window because that does put a lot of pressure on. Have you seen that happen before too?
Oh yeah, absolutely. I have friends that definitely did that when trying to conceive. They're like, oh no, I never tell him.
Yes,
it's just strike attack.
Yes, absolutely. But I will say too that some things sometimes we offer our patients as well is to say, look, maybe we should have your partner talk to their primary care doctor. A lot of times you can even do online appointments that are fairly anonymous to be able to get a Viagra or Cialis prescription if needed, so that when that pressure comes on, you're not having to miss that whole month if you're not able to do what you need to do. So okay, so I've been getting asked a lot about these new fertility monitors that are kind of like a very fancy ovulation test. So not only are they measuring LH and estrogen, but also measuring progesterone and FSH, your favorite FSH and everything. So I was just going to see, have you kind of seen the ads on these? And
I get targeted for these ads. So yeah, definitely seen a lot of them. I have to be honest, I haven't clicked on all of them. I haven't fallen for my clickbait, so I haven't seen exactly what all they're testing. I definitely have some concerns. My understanding is most of them are urine testing still, right? So I definitely have some concerns about monitoring a lot of those things, but just purely from urine testing. So.
I definitely think it's interesting. When I've looked, to me, it's just the results aren't surprising. Like you and I just know what the hormones do in a cycle anyway. So, I've had patients show them and I'm like, yep, that's, your estrogen level went up, then you surged your LH, then your progesterone level went up. To us, it's kind of like, we know this happens. But I can understand from a patient perspective, it might just be interesting for you to see and to know. So I don't think it hurts anything at all to have them, but it's not anything that I would recommend to a patient because certainly it's expensive and just not needed. I don't think it really helps in most cases for patients. So
sometimes too much information though can also be a cause for concern, and I think one of the most common things that I see when someone's really monitoring doing things like that, they're convinced they have low progesterone, right? So, and I get that question a lot, and then we kind of have to like go back from the beginning and talk about what does progesterone level do in your luteal phase or that second half of your pregnancy, and why they probably don't have low progesterone, and why their luteal phase is probably normal. But it's hard, like when you're tracking it and you see it, you're convinced of something, So we never want to introduce more information and then make you worry that something's not working correctly when it probably is.
And I think that's hard too, because as fertility doctors, we argue about what's a normal progesterone level even. I don't know that anybody has an exact set point. I certainly have something in mind of like what I like my goals to be, but it's not universally agreed upon. I will say though, again, when you're just kind of trying on your own, one of the things that I've noticed is if you start to spot a couple days before you start your periods, sometimes I do think that can be a sign of low progesterone, and you can kind of test it out yourself, because if you do a treatment cycle with us, and we usually give progesterone for most of our treatment cycles, does the spotting go away? And in the vast majority of the cases it does. It certainly can. But I think that's what's interesting. When we do treatment cycles, a lot of the things that we are doing are correcting progesterone, even if we're not outright explaining it. So for example, even just starting somebody on Clomid is a way of increasing somebody's progesterone indirectly. Or when we're giving somebody a trigger injection, that is then going to stimulate the corpus luteum where you ovulated from to make more progesterone. So there was all these things sometimes that we're doing to help progesterone. But I will say this is a very hot topic in our field.
Yeah.
And very debatable.
Definitely debatable.
Yeah, on the importance of progesterone. I think everybody would agree progesterone is important, but we just don't know what's the level it needs to be at, and could that alone be a cause for fertility or miscarriage or things like that. So
what I always tell my patient too is like, is it the chicken or the egg, right? So if you're having low progesterone levels, truly, or maybe lower progesterone levels, it's kind of petering out, you know, towards the end of your cycle. Well, probably what that means is you have a faulty corpus luteum. What does that mean? You probably didn't have a good follicle to begin with. What does that mean? Maybe your egg quality, your folliculogenesis, your ability of that follicle to grow is probably dysfunctional. So all that's happening and really going to affect your fertility down the road. But all we're seeing is the result of it. And we're fixing that result, but it's not fixing the problem. And so that's what I think patients really don't connect the dots on. And like, but I'm taking, my OBGYN gave me all this progesterone, you know, and I'm like, well, I mean, you know, we're dealing with diminished ovarian reserve, and we know that we have an egg quality issue here. So there's a lot of other things that really, is it just a sign of something else that's going on, you know? Same thing, I always see this with pregnancies. So patients who have biochemical pregnancies or early losses, well, my progesterone level was really low. You know, my OBGYN was checking it. Well, that was a sign that was a bad pregnancy from the beginning, right? So your CL wasn't being stimulated enough, you know, wasn't really seeing a good amount of progesterone to support that pregnancy. So, you know, if we supplement the progesterone, is it going to fix the problem? Probably not, you know. So it's all these things, you know. Is it a sign, or is it the cause, you know?
It's do we put a Band-Aid on it, or do we find the root of the problem? And I think that's so important because, you know, let's just give an example. So for miscarriage, so let's say a woman has hyperprolactinemia. Her prolactin levels from her brain are too high. It's causing her to have progesterone that's too low. If you just add on progesterone enough, that is not enough. You need to fix the prolactin level first, and then your own natural progesterone will go up and solve the problem. So I 100% agree. And I think that's what makes it so confusing and why people end up arguing about it and everything too, is that progesterone is important, but it's not a matter of just checking and adding it. You've got to really dig deeper.
The other thing, sorry, this is such an important topic though, because I get this question all the time, and I never want patients out there just be worrying about their progesterone. But the data that I always tell people about, the Phil Corey data out of Italy, he tracked cycles, he tracked progesterone levels very carefully, probably some of the best data out there. How is progesterone released in the luteal phase? Well, it's released in a pulsatile fashion. When you have someone checking your progesterone level at an isolated period of time, your progesterone spikes like this. So where are we testing it? Are we testing it maybe at the low end of your spike or at the top of your spike? Hard to really know. Okay, so unless someone wants to come in for daily progesterone monitoring, probably not going to volunteer for those daily blood draws. It's really difficult to know if you have inadequate progesterone in the luteal phase. So be very weary about someone telling you that your progesterone is abnormal, because they may just be misinterpreting. You know?
Well, and even beyond trying to get pregnant too, I think it's something for women to be aware of. Even when you're not trying to get pregnant, I'm seeing lots of women being told all of the problems they have are because they have low progesterone. And then I'll find out that they had their progesterone checked when they're on their period. And I'm like, your progesterone's supposed to be low when you're on your period. That's where we just know that menstrual cycle so well. We could draw it in our sleep. And we know that for the first half of your cycle, your progesterone level should be less than 1. That is what they are supposed to be as women. It's not until after you ovulate that you get a big increase in your progesterone. So I am alarmed sometimes when I'm seeing that. And I will say too, again, sometimes people think, oh, I need more progesterone, and so then they're giving it to themselves. You can even get progesterone cream. I saw a patient who was taking progesterone cream all the time. Well, here's the problem. If you're taking progesterone cream all the time, that's essentially birth control, because progesterone can actually keep you from ovulating if you're giving it at the wrong time. So there are a lot of nuances to progesterone supplementation, and if you're not an expert in it in the field like we are, then really it can be working against against you. And I've seen this a lot from patients who, for example, maybe saw a chiropractor or kind of were self-treating and really were working against themselves. So.
Yeah, that's scary with a cream. I haven't had a patient do that. Oh gosh.
Yep, I've had that, and or even just other types of progesterone pills. They were just taking every single day because they said I have low progesterone. Oh gosh. And I stopped the progesterone, and then she got pregnant right away. She thought I was a miracle worker. I'm like, nope, I just stopped her birth control. So yeah. So okay, very good. Well, if you guys have any questions or anything, please let us know, and keep giving us suggestions for topics, and we'll be happy to give you guys some more to talk about.
Have a great week.
Bye.